This is the chapter for Yeomans on classification of spinal arteriovenous lesions by Dr. Michael Mooney, Dr. Louis Kim, and Dr. Robert F. Spetzler. The key concept of this chapter is to present a classification system based on anatomical and physiological parameters. They are 6 categories: extradural arteriovenous fistulas, intradural dorsal arteriovenous fistulas, intradural ventral arteriovenous fistulas, the intramedullary arteriovenous malformations, the intramedullary arteriovenous malformations, and the conus medullaris arteriovenous malformations. The historical perspective of arteriovenous malformations have been recognized since 1888, and the first report of a surgical ligation of a spinal arteriovenous fistula was performed in 1911. There has been a large number of subsequent descriptions and classifications. In an effort to synthesize these past contemporary nomenclatures, and the more recent ones where type 1 through type 4 was used, we have separated these lesions as we initially presented and recognized that the new category of conus medullaris is an appropriate distinct entity. So the classification scheme, as depicted in this next slide, is divided into these 6 types of lesions as listed here. The classification is if there's an arteriovenous nidus on angiography, then it becomes an arteriovenous malformation. If there's a direct connection and there's no intervening component of a network of small vessels, then it is classified as a fistula. The fistula is divided into intradural and extradural, and the intradural into those that are fed by the anterior spinal artery and those that are fed by the radicular artery, and then those that are from the anterior spinal artery are further subdivided into giant, medium, and small. The arteriovenous malformations are divided into conus, extradural, intradural, and the intradural arteriovenous malformations are further divided into diffuse and compact. Here's a comparison of the Spetzler classification with the previous nomenclature. The extradural arteriovenous fistulas are relatively uncommon and can be elegantly treated with endovascular techniques, rarely requiring, at this point, an open surgical approach. Intradural dorsal arteriovenous fistula, the most common, is the dorsal one, which is a unique fistula in that the fistula is intradural and creates a very high venous pressure, which causes the myelopathy that is the typical clinical presentation. Although endovascular techniques are also utilized, the simple ligation of the fistula intradurally leads to a cure, whereas with endovascular techniques, the risk of being too proximal or too distal is present. The ventral arteriovenous fistulas are a connection between the anterior spinal artery and its associated veins, and they can be very large, providing progressive symptoms, and they can be small with associated aneurysms and present with subarachnoid hemorrhage. They, as opposed to the dorsal ones, are fast-flowing and typically do not present with myelopathy unless it's from compression. Next, the extradural, intradural arteriovenous malformations are a really metameric arteriovenous malformation, and they require for treatment everything that we have available, especially endovascular techniques. The intramedullary arteriovenous malformations are really the true arteriovenous malformations. They come in two types, the compact or glomus type, often fed just from the anterior spinal artery, and then the diffuse type, which is much more common, which tends to be lateral, although also involving the spinal cord. The conus medullaris arteriovenous malformation is anatomically specific to the conus and unique in that it has both a arteriovenous and a fistulous component, surely mitigated through the fact that this is the angiographic basket of the spinal cord, where there are distinct connections between the posterior spinal arteries and the anterior spinal artery. And indications for treatment require both endovascular and microsurgical techniques. So in conclusion, this particular classification has the advantage of being based on an anatomy, physiology, and provides logical treatment considerations. Thank you.